Our next topic would be the management of the contracted socket and the evolution of the Putterman clamp by Associate Professor Pete Setwood. He is an Associate Professor of Ophthalmology in the Division of Oculoplastic and Reconstructive Surgery, Department of Ophthalmology, University of Illinois at Chicago, and Illinois Eye and Ear Infirmary, the United States of America. Please welcome him on the stage.
All right, so I have the honor of having the worst time slot following Dr. Machima because that was a very good talk, so I have to follow that. But to her credit, she is an excellent cataract surgeon. Actually, I had her do my father's cataract surgery a few years ago. So I want to thank her and Dr. Sakchai and the organizations for having me here today. Not only is it an honor for me to speak here, but I downloaded this picture this morning. This is Chicago this morning, where it is minus 5 degrees. So it is a lot more comfortable here in Vientiane. When I was thinking about what I wanted to talk about today, I had a couple goals. And the two goals were, number one, I wanted to find a topic that could be relatable to most ophthalmologists and not just only an oculoplastic surgeon, because at a setting like this, I think it's important that everyone can kind of take away something from it. And secondly, I wanted to take advantage of the opportunity to maybe talk about some of the things that we do at the University of Illinois that may be a little bit different than elsewhere in the world. So, as this relates to the previous talk, I often get to attend talks and hear about some amazing technology and advances in ophthalmology, and in our field we see this quite often. So right now we have the retinal implant with the ARGUS 2. There's things such as the femtosecond cataract surgery. There's artificial corneas and keratoprosthesis, and now I think there's even an endoscope for glaucoma surgery. And so this is all fascinating work. So I often go to these meetings, I listen to these talks, and then I go home and go back to my division and think about oculoplastics. And I'm humbled by the fact that I'm still using the same equipment that we used in the 1970s. This is the Putterman ptosis clamp that Alan Putterman helped devise in 1975. This is the one that was recently just released by Bausch & Lomb in, I think, 2014. So not much has changed other than the shape. So in close to 30, 35 years, we haven't made too many advances in that field. But I think, what I want to talk about today are using the same old tools to do different procedures. I looked this up also. If you look in the primary textbook that we use to teach the residents in the United States, you'll see that this procedure with this clamp is primarily used for mild ptosis. So one of the take-home messages today about this clamp is that it can be used for a lot more than mild ptosis. And I think ptosis is something that probably everyone in this room sees. So what we're going to do today is we're going to describe the exam and the procedure pretty quickly. We're going to go over the different uses in ptosis, and then we're going to talk about an alternative use. So really quickly, when we think about a patient who's coming to you for a droopy eyelid, just like anywhere else, they need a very thorough history. So you want to know if they have any history of dry eye, any history of thyroid eye disease, previous eye surgery or eyelid surgery, any history of trauma, any variability. And then you want to do a good exam. And these are some of the measurements that we feel are important when evaluating a patient with a droopy eyelid. Things such as the palpebral fissure, the margin of reflex distance, the margin of crease distance, the fold distance, and ultimately the lobar function. And just real briefly, a quick review of these. This is the palpebral fissure, or the distance between the lower and the eyelid, the margin of reflex distance. This is primarily how we grade ptosis, and it's from the light reflex to the upper eyelid margin. The margin of fold distance is the distance from the eyelid margin to the skin fold, and this has a lot of cosmetic consequences, as this is often associated with aging, the lower it gets. When you look at the skin and the brow. The lobar function is a quick review. I think this is the most important measurement in determining what type of surgery you do, and this is the total amount of excursion, so the total difference between down gaze and up gaze, and this is the amount. And then the phenylephrine test where currently we're using 2.5% phenylephrine to see the effect on the eyelid position. And then this is my algorithm. It's very basic. If a patient has poor levator function, then they get a frontalis sling. If they have great levator function, then it depends upon the phenylephrine test. So good, moderate or great levator function with positive phenylphrine test over uveectomy. And at the University of Illinois, I would say that's probably about 90 to 95% of cases get uveectomies. So going back to this clamp. So this is the clamp that Alan Putterman made in 1975. This was devised at the University of Illinois, and I was Dr. Putterman's fellow, so I do have a little bit of a bias. So what we do is we use that clamp to shorten, if you will, one of the two primary muscles that elevate the eyelid. And so as a quick review, the two muscles that lift the eyelid are the levator aponeurosis and the Mueller's muscle. Now the Mueller's muscle, it's important to remember, attaches to the superior border of the tarsus, so at the very top of the tarsus, as well as to the underbelly of the levator aponeurosis. And that's important to remember because it will tell us why this procedure works. And then the levator attaches to the interior border of the surface, interior surface of the tarsus. And just real quickly, I have a video, but we'll just go over this real fast, is that the muellerectomy, we flip the eyelid, we invert it, we take the tissue, the desired amount within a clamp. We then run a suture about 1 millimeter beneath, and then we cut the tissue in the clamp and then close. So then, we won't show all of this video, but we'll show some of it. And I've kind of modified this procedure from what Alan made in 1975. So what I do now is I measure half the distance that I want to resect. So if I want to do an 8 millimeter resection, I measure 4 millimeters and place a marking stitch or a traction stitch about 4 millimeters superior to the tarsal border. And by doing that, then I can tent the amount of tissue that I want to lift. When we tent that, then we take the clamp to imbricate the amount of tissue we want to get. So we grasp the tissue all the way to the tarsus, and then we run a suture, like I said, about 1 millimeter before. So I think everybody has a gist. We don't have to really show all of it, but a few take-home points about doing the procedure. The location of the clamp is important. It must be perpendicular to the tarsus. It's important that it's not tilted, because one of the advantages of this procedure is it allows you to get a very good eyelid contour and shape. This only holds true if you place the clamp in the right location. It needs to be centered to the tarsus, not centered to the eyelid, centered to the tarsus. It needs to go all the way to the tarsus, because if you don't, you may not actually get Mueller's muscle. The suture needs to be passed about 1 millimeter beneath the clamp. Anything less than that, you risk cutting the suture when you cut the tissue. And then when you're excising the tissue, it's important to bevel the blade up. So I always tell the residents and the fellows that you want to scratch the clamp, because that minimizes the risk of actually cutting the suture. And then I always like to look to see if we can find Mueller's muscle. So far I haven't talked about anything that's new. This is a procedure that's been around for over 30 years. It's gaining some popularity here in the United States. I think it's actually gaining some use in Asia as well. So nothing's new, but just as a couple pre-op, post-ops, you can see there's good eyelid elevation. You have a good lift. The lashes are in a good position. That margin to fold margin to fold distance that I was talking about has gotten a little bit smaller, but it's still in good position. Again, mild ptosis. So why does this work? So when I was a fellow, 12 years ago, I always asked people why this worked, and no one really knew. And even Dr. Putterman wasn't quite sure why it worked. And so what we decided to do is we were going to do this procedure on cadavers, and then we would exonerate the specimens, see the specimens, and have a pathologist look at it. And so that's what we did. We took it to the cadaver lab. And I don't want to get too technical, but what we basically found was, in addition to excising conjunctiva, shortening Mueller's muscle, we also advanced levator aponeurosis. And why is that possible? The reason that's possible is because Mueller's muscle is actually attached to the levator aponeurosis. So that's why you were able to shorten the eyelid and advance all the muscles. And you can see that here if you look between these two slides. On this histology slide, you see that the levator aponeurosis actually advances. And it's depicted here on a diagram where you can see the levator aponeurosis fold over on itself. The amount of resection, you may ask, Does it matter how much? And if you do a literature search, you'll see there's, I don't know, probably 6 or 7 different papers on how much to resect. I have the more popular ones listed here, but what we decided to do was we were curious, does this even matter? So one of my former fellows, he went through and he kind of looked at all of my cases over the last few years, and ultimately what we found is it doesn't matter. Between a small range of 8 to 9.5 millimeters, the amount of resection doesn't have any statistical significance. So I came up with the idea that, and this is what I believe, an 8 millimeter resection equals what you get with the phenylephrine test. So if it's a 2 millimeter lift with phenylephrine, an 8 millimeter resection will give you 2 millimeters. If it's a 4 millimeter lift with phenylephrine, the procedure will give you a 4 millimeter lift. And I know this goes against everything that we've been taught, but our studies show that this is true. So again, so far I haven't talked about anything new, but this is where we are. I want to talk about its uses in ptosis first of all, but not just for minimal ptosis. So we'll talk about it. And I'm not here to tell you that it's not for all cases, but it is a good tool to have in your bag. So it's a good tool, and what we found in the United States is that more and more oculoplastic surgeons at least are using it. So about 3/4 of all oculoplastic surgeons at least use this procedure somewhat in their repertoire. And why do they use it? They use it because it has many advantages. It's reliable and it's predictable. I tell the patients, this has very little to do with my sense of artistry or my skill. This is based upon an algorithm upon thousands and thousands of cases where we can make this case and we can reproduce the results. It's more efficient. You get a better contour and shape, and there's no skin incision. And you can see here, this is a patient who didn't have a nuclerectomy. This is a patient who had the traditional external levator advancement, the traditional ptosis surgery, and you can see he's peaked. No patients coming to see an oculoplastic surgeon to leave with these peaked eyelids. Again, reliable, predictable, good contour. This patient has a good contour. So let's talk about some of the things that we can use it for. We can use it for severe ptosis. And like I said earlier, if a patient has a 4 millimeter lift with a phenylephrine response, they can get a 4 millimeter lift with their ptosis surgery. And so we looked at our patients, those patients, we had 91 patients with 141 eyelids who had an MRD of 0 or less. And that's how we define them as severe. And what we found out of those patients is they had just under a 4 millimeter lift, 3.8, if you will, of a lift. So these patients with severe ptosis, so this is a gentleman, and I think everyone in the room can agree, has a severe left upper lid ptosis, right? This isn't mild ptosis. His MRD is -2. He had a very good response to phenylephrine. He had a very good levator function. He had the procedure, and as you can see, he's had a great result. Same thing here, severe ptosis, great results. Same thing here. How about in children? For many years, this was thought to not be a good procedure for children, but in those children who have a good levator function and a great response to phenylephrine, they can have this procedure. So this study wasn't performed by us, it was performed by Dr. Mazo in Dallas, and he proved that you could do this procedure in kids, and we feel the same way, right? Good response, good lift, this is a great result. He's very symmetric, both in his contour as well as his height. This is a perfect example of a girl, as you can see in the upper left photo, this is how she presents to the clinic with a left upper eyelid ptosis, and in the bottom left, that's her response to phenylephrine as depicted by the picture at the bottom. And then we were able to mimic that response in surgery. So I think this is a great result. One of the downsides, however, I just want to be very honest, is if you look at her right upper eyelid, it's a great lift, but the one thing she's missing is a crease. So by doing this procedure, you don't necessarily give the patient a crease. How about in patients who don't have a great response to phenylephrine? Well, what you can do for them, what we found is that as long as they have some response, you can do the procedure, but you may have to take a little bit more, or you may have to take a little bit of tarsus, but this procedure can be performed in those patients who have a poor response. So this is a woman who came to see me for her left upper eyelid ptosis. We put in the phenylephrine, she had a so-so response. We decided to do the procedure anyway. We took a little bit of extra tarsus and she had a good lift. How How about in patients who have keratoprosthesis? So I'm sure we have a couple of cornea surgeons in the audience, and they would probably be somewhat appalled that I would remove conjunctiva in a patient with a keratoprosthesis. But we've actually discovered that this procedure actually doesn't reduce the amount of tear production. And in select cases, this can be done in patients with keratoprosthesis. Now, the goal isn't the same as everyone else. We aren't trying to get a symmetric result. We're just trying to lift above the pupil so that the patient can see. At the University of Illinois, my cornea colleagues actually do quite a number of keratoprosthesis artificial corneas. And the way we think about it is these patients go through a lot. They go through a great deal to be able to see again. And it doesn't do anyone any good if their eyelid continues to be blocked. So we want to lift them, but we tell them that we want them to be undercorrected. So this is another perfect example. She can't see her keratoprosthesis. You can't see. In the upper photo, you can't even see the keratoprosthesis. If you can't see it, she can't see out. So then we can do the procedure. Horner syndrome. It's another case where we found that you can do it. So this is a girl who has all the characteristic signs of Horner's. She has meiosis. She has anhidrosis. She has upper lid ptosis. She has an elevated lower lid. And she has iris heterochromia. So she has the hallmark signs of congenital Horner syndrome, and she underwent ambulorectomy and looks great. You do have to watch out for overcorrection in that thing. MMCR with blepharoplasty. So even though you're making an external incision, I still perform ambulorectomy, and the reason is because I think we get better contour, we get better shape out of it. And really the reason I picked this topic to talk about is because I want to talk about this last thing, and that's alternative use of this clamp, and it's just not for ptosis. And so I'm sure many people have seen patients like this where they have what we call tarsal ectropion. This isn't just mild ectropion or slight ectropion from loosening of the lower eyelid or weakening of the lower eyelid. So this type of patient can't be repaired with the traditional tarsal strip procedure or application of the lower lid retractor. This patient needs actually some resection of the posterior lamella. And so a handful of years ago, one of Dr. Putterman's former fellows kind of started playing around with the clamp to see if we could use this procedure to do a lower lid resection. And so we published this a handful of years ago. And what we found is that you could. And what I wanted to show here is what are we targeting? We're targeting the lower lid retractors and the conjunctiva of the lower eyelid. Same clamp, nothing different. We had one of our illustrators draw this for me. And this is the basic, it's the same procedure, just flipped. So we'll show it briefly, I won't show all of it, but basically it's the same thing. We're gonna take the lower eyelid, we're gonna pass a traction suture, we're gonna flip it. And I traditionally only do a 6 millimeter resection. So here I'm measuring 3 millimeters inferior to the inferior border of the tarsus. We pass the traction sutures. We're gonna place the clamp, there's the traction sutures, we're measuring the distance. We're going to take a clamp and then we're going to run the sutures. The procedure it's identical. And again, I'm not the kind of person who just believes in something, so we have to figure out why it happened. So we did the same thing. We performed the procedure on cadavers. We exonerated the specimens. We fixed the specimens, and we looked. And what did we find? We found that you actually advance and placate the lower lid retractors. And so here are a couple cases where that's worked. This is a patient who had severe right lower eyelid tarsal ectropion. The procedure, in addition to a tarsal strip, was done. Good repair. Same thing here. This is the one that always gets the biggest effect. So this is a woman who's had so many surgeries, saw a couple ophthalmologists, and actually never got better. It wasn't just a surgery to fix her, but we found out she was having all these complications and all this redness and injection from her glaucoma medications. So we kind of took her off her glaucoma medications, kind of treated her cornea. She still had a severe tarsal ectropion. We did the procedure. We were able to invert her eyelids to bring her back to a good normal position. So I think this is a very elegant procedure. This is something that's new, something that you can do very quickly in your clinic and get a pretty good result with tarsal ectropion. If you don't have the clamp, you can just use a set of hemostats. So in conclusion, there are many uses for this clamp. It's the same clamp that was being used in 1975, so nothing has changed, but I think it does have a lot of good uses. I am going to go to my second talk, and then we can do the questions after that, if that's okay with everyone. So, I was asked to do two, so we will go to management of a contracted socket. The reason I picked this, again, in an audience like this, everyone in here eventually is going to see a patient with a socket. you're going to see a patient who's been enucleated, and so therefore you're going to have to learn how to deal with their complications. I do have to give a special thanks to Jeremiah Tao. He's an oculoplastic surgeon at UC Irvine, and Scott Jones is my former fellow. They kind of helped with this talk by giving me a lot of the photos. So what is a contracted socket? You'll see this is when the fornices are too small so the patient can't retain a prosthetic. And if a patient can't retain a prosthetic, they're bothered by their appearance. So typically these patients have a history of radiation, infection, burns, they've had multiple surgeries, maybe their implants extruding, and so they're unable to wear the conformer or their prosthetic. And typically we classify these as into mild, when they may just have a little intropion like the woman here. You can see the upper eyelashes are turning in, and this is easily fixed with a blepharotomy or a transmarginal rotation, or it can be moderate where maybe they aren't able to keep their prosthetic, and so you need to reform the fornix, and they may or may not need a mucous membrane graft, or it can be very severe where there's vertical and horizontal shortening, there's obliteration of the eyelid, and these patients definitely need a mucous membrane graft and a conformer. So really quickly, what you can see here, this is kind of hard to see, but if you trust me, but the left lower eyelid, the eyelashes are actually turned in, rubbing against the prosthetic. The patient feels irritated. The patient did need a big procedure, just a small transmarginal rotation to turn the lashes out. Now, in some cases, the patient may have a shortened fornix, and what we recommend there is you make an incision into the fornix, and once you make an incision into the fornix, you go to the underlying scar tissue, and you dissect the scar tissue, you create a plane all the way to the orbital rim, and then you close the conjunctiva, and occasionally that'd be good enough. Even in those instances, however, I put a silastic band. You can use a retinal band, and that will help kind of secure and reinforce the fornix to the orbital rim. Sometimes you just can't get away with it. You have to take a mucous membrane graft. I think one of the easiest places to take one, especially if you don't have a lot of experience with this type of surgery, is just to take it from the lip. It's an easy location. You don't have to close the lip. Obviously, you have to clean it, but you don't have to close it. A couple things to note: you have to stay posterior to the vermilion borders. You want to be a little bit further away so you don't alter their cosmetic appearance of the lip. And you want to stay medial to the canines, which are these teeth here. And the reason is that doing so allows you to avoid the mental nerve, so they don't get anything on this. Sometimes you need a really large graft, and in those cases you have to take buccal mucosa. It's important to avoid Stenson's duct. Anyway, once you get the graft, you suture it in, and then again I put some silicone band, typically a retina band, and this extra tissue, as well as the releasing of the scarring, can help you create this fornix so that the patient can wear a prosthetic well. And this is a patient who had what we would classify as mild contraction of his socket. However, he wasn't able to wear his prosthetic, so we went in. He had a mucous membrane graft, and this was actually done by one of my friends, Dr. Jeremiah Tao, had put a mucous membrane graft, reinforced and created the inferior fornix, and the patient's able to wear his prosthetic and do well. Same thing for this young man here. In very severe cases, I rarely feel like this is needed, but there are those out there who do, so we'll go over it very quickly. You may have to actually put a full conformer in, and in these cases you make an incision by the upper and lower orbital rims. You dissect all the way through. I take a drill through the bone, so that you can pass the suture layer. We take that mucous membrane graft that I talked about, we wrap a conformer, and then we suture it in place, and we leave it there for about 2 months. Secure through the bone, something like that. But kind of what I want to talk about today, because this is something that's more common, is we see exposed implants. And I tell patients all the time, these implants weren't made to be in you. Eventually, if you live long enough, these implants are going to start coming out. So the question is, what do you do when these patients come out? Well, the definitive treatment is you could just do a dermis fat graft. You just take the implant out, and you can take a dermis fat graft either from their abdomen or their buttocks. I prefer the abdomen because it's easier to hide kind of at the waistline, and they can hide it in their underwear or their shorts so they don't have a scar. But what we typically do is we take a small dermis fat graft. This is a case of mine where the patient was extruding. He didn't want any more surgery. He just told me he wanted one more surgery and be done with it. So we took it off his abdomen, sutured in place. It's a very straightforward procedure. This is him on the right coming into clinic with an exposure. On the left is about 2 months afterwards, and you can kind of see the dermis. That white part is an infection. That's just dermis. That's fine. This is him about another month or 2 after that. And he's able to wear his prosthetic, and he does well. Okay, so that's the definitive treatment. However, sometimes a patient would rather, not go through this big surgery and not have to take a dermis fat graft. So the traditional teaching is that we take these exposed implants and we put a temporalis fascia and we release the tissue, go underneath the conjunctiva, identify where tenon should be, release some of the scar tissue, and then we harvest temporalis fascia from there just behind the hairline, sutured into place. Again, traditional teaching. But the reason I wanted to talk about this is because this is what we've been doing at USC. This is on we've had a series of these that we're publishing real soon. We're using the posterior auricular muscle. So does anyone in here know what the posterior auricular muscle actually does? I didn't either, so don't be surprised. It does very little. Can anyone in here actually move their ear? You can? So we have one person here who actually uses his posterior auricular muscle. It is exceedingly rare. I don't know the number, but patients who have the ability to move their ear are really the only people who can use that muscle. I can't. So that muscle sits back there and does really no good, except for what we found a use for it. We found a use for it in those patients who have exposed implants. The muscle and the fascia provide a very good graft that can get vascularized, and so we use that. So this is from our illustrator who kind of drew up a procedure, and I have a video I'll show you real fast. And so what you do is you go in where the exposure is, release where all the scarring and the cicatrice is, you measure the defect, because the defect can be a lot bigger than it was when the patient presented. We go behind the ear, we make an incision behind the ear, we identify the posterior auricular muscle, we take muscle as well as a little bit of fascia and suture it in and cover it with conjunctiva. So I'm actually shooting the video. This is my fellow. So what we're doing is we're releasing the tissue just like I talked about. We want to make sure we get a very good space between the implant and the conjunctiva so that the graft can fit. And once we do that, we measure the defect. And you can see the defect is quite large relative to what we thought. So once we know how big it is, then we go get the graft. And typically, I recommend sizing the graft about 25% larger than the defect that you have. And then this is us taking the graft out. Typically, we incise it with a 15 blade at first, and then we remove the rest with a pair of scissors. And then you get a graft. It looks about like that. So on the bottom, so what you're looking at is a little bit of muscle, and on the bottom that's touching the towel is fascia. And then we suture it into place. And the important thing is you want to get it underneath the conjunctiva. So you're suturing the graft to tenons. And typically I actually use a double arm suture, have them pass it all the way deep. Sometimes I even have them go ahead and externalize it. The only problem is you waste a little suture doing that, but that's okay. That way that the graft is spread out deep underneath the conjunctiva. And so this is it. So this is the graft in place, sutured to tenons, and then we're going to close over it by suturing conjunctiva. And in the interest of time, we won't show suturing of conjunctiva since that's pretty straightforward. But basically it looks like this, and then we close the ear. And the good thing about a graft behind the ear is you don't really have to worry about the patient's scar since no one's looking behind everybody's ear. And this is a pre-op, and 3 months later, this patient has actually been over a year and still doesn't have an extrusion. Same thing here. And they're able to wear their prosthetic. They're no longer extruded. They didn't have to have a dermis fat graft in. They just had to have a small surgery. That is it. Thank you very much for having me.
Please, someone bring the microphone to the ladies in the back of the room, please.
I have a question about the process.
Yes.
If the patient presented with ptosis and the phenolphthalein test is positive, and if she wants to correct the ptosis, but also she wants to do the decrease for the cosmetics, which procedure do you prefer? Do you still prefer to use the myelectomy and followed by decrease surgery, or do you use other procedures such as prevent the advancement?
My answer is I prefer to do a myelectomy because, at least in my experience and in my hands, it's more reliable. So you're talking about a patient who's coming in with a cosmetic expectation, and so in my hands, what's going to give them the best cosmetic result is the myelectomy. So I'll perform a myelectomy and at the same time perform a lid crease performing procedure. It is the only thing. It's an extra incision and an extra, 10 minutes. But I think, especially in a patient who has a very high cosmetic expectation, that is probably the best choice for this for me.
May I ask about the complication about the overcorrection of the MMCR, please?
That's a great question. So, the overcorrection is exceedingly rare with the MMCR. At least at our institution, it's more common to get an overcorrection with an external levator advancement. I never say never, but in 10 years, I think we've seen 5. And the reason that is, this amount of resection, an 8 millimeter resection, is really hard to get an overcorrection. The only way, when we looked back at our series, is that the surgeon actually did a larger resection than he intended. The measurements were off, but they actually took too much tarsus. So if you stay away from taking too much tarsus, it's exceedingly rare to get an overcorrection. You're more likely to get an undercorrection, and that may be because you didn't get enough Mueller's muscle, but overcorrection is exceedingly rare. Yes, sir.
Thank you very much, Prof. Can I ask 2 questions for you? One is there any role of frontal sling in the ptosis? And the second question is the phenylephrine, does it act on the levator dehiscence?
So the first question, at our institution, I can say the role for frontalis sling is for patients who have poor levator function. So in the patient who has levator function of less than 5, and the ability to, from all the way from looking down to looking up, if they don't have great function, if they don't have great lift, those patients require frontalis sling. With response to phenylephrine, so the reason that we believe, and I'm not saying we're right, but the reason we believe that phenylephrine will still work in patients with levator dehiscence is because there's never complete dehiscence. When you go in there, there's still some attachments, right? So when you're resecting Mueller's muscle, you're actually still advancing and folding over levator. You may not be resecting levator, but you're still advancing levator.
Thank you. Another question is, we're doing the bilamellar dorsal rotation and entropy. So if it is overcorrect, how shall we relieve it?
For entropion?
Yes.
So a patient with entropion, if you overcorrect, how do you relieve that? That's a great question because that's tough. And I think every surgeon runs into that problem. I think we've kind of played around and we found that our best results happen when we get a slight overcorrection, a very slight overcorrection on the table. Meaning in the OR, we aim for slight overcorrection and then typically that will go back into a normal position. I think when we've gotten ourselves in trouble is when we shoot for severe overcorrection.
Yes.
Then it typically doesn't go back. So on the table, I think it's important to make the adjustment at that time and to target a slight overcorrection.
Thank you very much, Prof.
Any questions? So I kind of have like another question for you. I just wonder that have you had any experience about the eyelids for Asian people, because it's kind of like different as you know from Caucasian. Yeah.
Are we talking about for the ptosis surgery?
Yeah, for the MCI, is it like the prediction of the results is it the same?
So that's probably I want to say that's the best question, and the reason I'm going to say that is because I have had some experience, yes, and we believe it to be true. We believe that it works very well in Asian patients. With that being said, being in physicians and academic physicians like many of us, believing it to be true and proving it to be true aren't the same thing. My now just freshly minted former fellow who's Thai, his project for this coming year is actually we're going to perform this procedure in Thailand on Thai patients to prove to see if those results are comparable to Caucasians. So next year at this meeting, I hope that you can get the answer.
Okay, thank you.
Okay, any more questions? I believe not. For the next one, I'd like to ask Associate Professor Kampur to present the gift to both Manchima and to Ajahn Pete.